Fran, is Anitha with you?
No, as of right now, it's just me.
Okay, so if she arrives, just let me know.
Sure.
All right, did everyone get last week's lecture? Were they able to watch it, listen to it?
Yep.
Yes.
Any questions or concerns regarding chapters 22 and 23? Anything that just you couldn't get?
No.
No.
All right, and how are the homework assignments going? Is everyone pretty much getting the majority of the assignments? There's nothing really wearing you down? How are those reports doing? How are you all doing with the reports?
Okay.
All right. They're not fun. But if you can keep in mind, in the real world, you're going to have people who you can ask questions. And I apologize. I'm still hoarse. It's my asthma, and it's the cold weather, and it's the dryness. So I'm sure you heard it in the recording from last week's lecture, and I apologize for that. So I might need to call on you guys a little bit more often. So tonight we're on week 11, and I just wanted to touch upon, we're coming near the end of the course here, and it's time to start thinking about the national exam. I will repeat this information again because I said it in the first part of the class. But the national exam is about time management. That is why on Evolve you have timed exams. And from here on out, it probably wouldn't be a bad idea, and I recommend it to all of my students, is to use an egg timer. Allow yourself 2 to 2.5 minutes to do the reports when you come to the reports. On the national exam, you will have multiple choice. And we will have 3 simulations of that type of exam for you at the end of the course. That is that red CPC Physician Coding Review exam book that you have. And I'll have you bring that in the last class so that we can go over how I want you to move forward with that. So Daniel, I see that. Yeah, that's kind of a maroon mahogany type color with some rainbows at the bottom. So they changed it. No, I'm all booked out too. So the national exam is 5 hours and 40 minutes. The simulation exams that we have prior to is 5 hours and 40 minutes. Now, they are on Evolve. So if you don't have access to that exam review on Evolve, you just shoot me an email. I don't usually set them up the first part of class because I want you to get through class first. I don't want you to go on and get so overwhelmed by the exam that it kind of puts your mind in this fear mode of, oh gosh, how am I going to do this? Okay? I will honestly tell you that I love what I do. I love the billing, I love the coding, and I love the teaching. So for me, as I talked about it early in the class, it's about solving those puzzles. If you like to put puzzles together, it's about finding the right pieces and making them work. So I'll give you really good. For instance, a new specialty that I've been working with is immunotherapy and an allergy type of practice. And so for me, it's not about learning the new codes, because every specialty has their own set of codes that they use. It's really about learning how the insurances will pay for these codes. So what you have learned here will take you anywhere, okay? You will be able to do the work wherever you go with these resources. What it comes down to is learning the niche, okay? So ask questions. That's why I welcome you to ask questions, whether it's via email or in class, because there is no stupid question. I don't believe there is ever a stupid question, because what you may ask, someone else is probably thinking, just don't want to ask it, okay? So getting through these next few weeks is really about completing that foundational work, and then moving into the simulations, which you will have 3 of them, 5 hours and 40 minutes. The first 2 you will do on Evolve. The third one, we come together and we do a mock exam. So I usually will plan it for a Saturday. And I usually send out an email that says, hey, here's a few Saturdays I have in mind, who can make it? And we go and we do the mock exam, and then you pick a date, usually a month or so afterwards, to go take your national exam. Now, you don't absolutely have to do it that way. I've had some students who have finished class and 2 weeks later taken the national exam, and most have passed. But if you're not ready for it, don't push yourselves, okay? The biggest reason most people do not pass the national exam is time management. It's not that they don't know where to find the information, because by the time you're done this class, you know where to find the information. The tabbing of these books helps you to find that information. It's time management. So start preparing yourself now. Use a little egg timer or stopwatch like I mentioned, and just allow yourself 2 to 2.5 minutes. Now it's going to be a little different because you're looking up the answers. You don't have multiple choice. But it will prepare you for the simulations we're going to have, and then the mock exam. At the end of the course, I will have the CPC exam application available for you. Actually, I will go ahead and put it online on Evolve. I think I have a section under there, lecture and common questions or something like that. I'll go ahead and put it under there. Just print it off. Go on the website, the AAPC website, locate an exam. You can go to New Hampshire, Massachusetts, Maine, find out when the next exams are, and decide when you want to sit for it. I usually say a month after we finish class, that's when you should be ready to take it, because by that time we've done the simulations, we've done the mock exam, and you should be ready to go. When you're filling out the application, I also will put on the website how to fill out the application. So I'll give you the blank one that you can print off and fill out. And then I will have one already filled out for you so you can see how you have to fill it out. There's a section on there about paying for it. You do not pay for it. It's already paid for as part of your course. When you fill out the application, you actually send it in to Amy, and she sets you up for the exam. And then the last class, I will also give you some tips about what you will need for the AAPC exam, how to get through the 5 hours and 40 minutes, and so on. How does that sound?
Sounds good. Doreen, I do have a question.
Sure.
You said on like a couple of Saturdays we're going to try to get together and actually have an exam.
It will be one Saturday, yes.
Okay, where is that going to be?
I usually try to have it over here at Mary Meeting, up here in Brunswick. Where are you?
Okay, well, I live in Rockland, but yeah.
Okay.
That's fine. So yeah, just as long as we have directions to it, I can find it.
Yep, absolutely.
Okay.
Yep.
Thank you.
You're welcome. All right. So let's go ahead and open your textbook to page 682, chapter 24. And what we will do is open our CPT book. I want you to open to page 318. All right, so the urinary system subsection starts with 50010 and goes all the way through 53899. All right, who can tell me how this is arranged? How is this subsection arranged? Yes, anatomical site. Great, Daniel. And hasn't that been the theme pretty much throughout the CPT book? Okay? Which makes it easier for us. Because if we think about it, all the way from our head down to our toes, it makes sense that they should put it in anatomic site, correct? All right. So this one is a tricky one. The uretopelvic junction connects what two areas? Now, the acronym for uretopelvic junction is UPJ. Do you remember reading that in the text somewhere? I'm going to give you 4 choices. The uretopelvic junction connects 2 areas. The first is the renal pelvis. Now, I'm not going to say the renal pelvis for all 4 of these because that's the first choice. The second choice is what you have to decide it connects to. All right? Ureter, urethra, prostate, or kidney. So the UPJ connects what 2 areas? The renal pelvis and the ureter, or the urethra, or the prostate, or the kidney. All right, well, the answer is renal pelvis and ureter. All right.
Doreen, Anitha just came in.
Okay,
Now
Anitha,
there's 2.
welcome.
Thank you. I was here last year.
All right, so Fran, if you can just show her what to have open, please. Let's start
Sure.
on page 62 in our textbook. So as I just mentioned, the urinary subsection is divided up by anatomic division. And we start with the kidney, the ureters, the bladder, and the urethra. And you see on page 318 in your CPT book, they give you a nice illustration to show you where are the kidneys, where are the ureters, the urinary bladder, and the urethra. So what are some of the procedures involving the urinary system? If you look over on page 319, we might have a drainage of a renal abscess. We might have some calculus removed. And you will notice that for the urinary system, there are 4 subheadings. And the subheadings are in red. The first one is kidney. The second one is ureters. The third is bladder. And the fourth is urethra. All right, so to follow suit, as we have in the previous portions of our CPT book, the subsection is further divided by procedures. So the procedures that you will find here in this section are incision, excision, introduction, and repair. When we talk about incision, it may be reporting exploration or drainage. Under your kidney subheading, 50010, under there, you will notice that it is renal exploration, not necessitating other specific procedures. This would be endoscopy. And when we look at the endoscopy codes, we are going to see that that is usually done through a previously established stoma, so an incision. Also, most of the cystoscopy procedures have 0 global days. So, if you see here cystoscopy, you might want to put a note next to it that says 0 global days. All right, and so paying attention to your endoscopy, also pay attention to the approach. It's either going to be through a previously established stoma, which is used as the entry point, which is created by placing a catheter through the skin into the kidney, or they will use an incision. When you are coding these endoscopy procedures, you must identify the entry method in order to assign the right code. So this is where, if it's not written in the documentation, query the provider. I do want to caution you, though, that the kidney is located in your retroperitoneal area. And each of the codes you see will be for a procedure. So renal exploration. What is renal exploration? This is where the diagnostic kidney procedure 50010 indicates that there is no further procedure performed. The retroperitoneal area diagnostic procedure is actually 49010. So renal exploration, pay attention to kidney or retroperitoneal. Renal abscess, this is where a kidney abscess, you use code 50020. If the radiological supervision and interpretation were performed, you would want to use a code from the radiology section, 75689. Again, if it is a retroperitoneal abscess, use code 49060. If it says exploratory, it means diagnostic. When you see exploratory, it means diagnostic. And if for some reason they do an exploratory procedure and a corrective procedure takes place, you do not bill for that exploratory procedure because they were able to go in and do something. Over on page 683, a nephrostomy. It's important to know here in this section the difference in the terms and to understand that the surgeon may start out performing a nephrotomy to explore the kidney and find a reason for the patient's urinary obstruction, and the procedure then becomes a nephrolithotomy when a calculus is found. So paying attention to those will be important. Down at the bottom of page 683, ESWL. This is the use of shock waves to fragment a calculus. How is it performed? This is where the patient is placed on a water-filled cushion on his or her back. And then, while the patient is under general anesthesia, shock waves are targeted to the stones, which are then pulverized with repeated shocks. And what is the benefit of this? Well, it's less invasive, and it helps to break up the stones and makes it easier for them to pass. Now, passing them may not be comfortable, but it's definitely less invasive to the patient, which means less recovery time. Excision, over on page 685 in your textbook. Excision. What is a nephrectomy? Fran, what is a nephrectomy?
It's removal of the kidney.
Yes. And what you need to pay attention to here in the nephrectomy section is that these codes are based on the complexity and the extent of the procedure. Also pay attention to the medical record documentation because it should indicate if the procedure was partial or total or laparoscopic or open, and if any structures are removed. Darcy, what is ablation? Tell me what ablation is.
The cutting away or erosion of tissue.
Yes, and it can be done by cryosurgery, laparoscope, and percutaneous. Would you agree?
Sure.
Good. Yes. All right. renal transplant. Renal transplant or renal transplantation. This is what they call backbench work. And this is where the retrieving of the organ happens. And it's taken from either a deceased person or a living person. This is where they prepare the organ from a deceased person or a living person. And you'll notice on page 320 in your CPT book, they have some notes right there for you to read underneath renal transplantation. And then transplantation without the nephrectomy, with the nephrectomy, and if it's a bilateral procedure, we would add the modifier 50. So when we talk about an allotransplantation, this is between two people who are not related. An autotransplantation is the transfer of tissue from one part of a person's body to another part of a person's body. And then over on 321 in your CPT book and 686 in your textbook, we learn about introduction. Introduction is where the aspirations take place. The catheters and the injections are used for radiography, insertion of guide wires, tube changes. And these are usually reported with the radiology components. So what you want to keep in mind here is that these include extensive notes, which you should read before you code. So now is the perfect time while you're doing your assignments to read these sections and highlight or underline the things you need to stick out. All right, and then at the bottom of page 686, and over on page 323 in your CPT book, we talk about repair. And repair is a pyeloplasty. What is a pyeloplasty? This is when they are working on the renal pelvis, using plastic or not. This is where they repair the UPJ. If it's a simple repair, it is a 50400 code. So, right in there, highlight simple. In your CPT book, 50400, highlight simple. Underneath complicated, code 50405. So, code 50405, highlight complicated. Highlight, underline, whichever you want. Again, you want these words to stick out for you when you're looking them up. The more that you can draw the eye to when you're looking up your codes will make it that much faster for you to find them. What is a congenital defect? Fran, what does it mean when we say they might have a congenital defect?
It was something that you were born with rather than that you developed.
Correct. So it's usually acquired. It's already something they've been born with. What does the closure of a fistula depend on? Well, when we are looking to close a fistula, it depends on the approach. It will either be abdominal or thoracic. Over on page 688, laparoscopy. Your laparoscopy codes are 50541 through 50549. They start on page 323 in your CPT book and go over to 324. What you will find underneath your laparoscopy codes are the ablation of the renal cyst or lesion or cryoablation and percutaneous. These codes are based on the extent of the procedure. So how far do they go? That's what we mean when we talk about to the extent of the procedure. Also, endoscopy on page 688 in your textbook. Your renal endoscopy codes are divided by the established connection between the kidney and the body exterior and the nephrotomy or pyelotomy. Once that is determined, then it is further divided based on the purpose. Is it a biopsy or is it removal of a foreign body or calculus? Your renal endoscopy procedures are less invasive than open procedures, and often they can be performed on outpatient basis. The ureter on page 689 in your textbook, the ureter. These codes are divided by the type of procedure: incision, excision. And then we have the laparoscopy codes, which describe the surgical procedures. Your codes here may be bilateral or unilateral. And if you look in your CPT book, you'll notice that there aren't that many codes for the ureter. It's just on a few pages. Incision on page 689 in your textbook, incision. The incision will report the open procedures. So it's either an exploration or a drainage. They will insert a stent. They will remove calculus. And the calculus will be based on the location of the upper third, the middle third, or the lower third. Remember, you have a laparoscopic approach as well as an open approach. The excision codes, or the excision category for the ureter, you'll see 50650 and 50690. It's just two codes on page 326 in your CPT book. And they talk about a ureterectomy. This is where the bladder cuff is excised or a total excision. The introduction will report any injections or manometric studies and change of stents and tubes. What is a manometric study, Fran?
Sorry. They use it to measure urine flow, kidney flow, and the pressure inside the kidney.
Yes, good. All right, and then laparoscopy and endoscopy over on page 690 in your textbook. The laparoscope is placement of the ureteral stent. The endoscopy codes are for procedures through an established stoma. So as you've learned throughout the class, your knowledge of medical terminology is very important here. Moving on to the bladder, page 692. (692) in your textbook and on page 329 in your CPT book. You will find a lot of bundled codes here under the bladder. For example, a urethral dilation is included with insertion of a cystoscope. So you want to make sure that you read all of the descriptions carefully for the site, the technique, and the reason for the procedure. You'll notice that underneath the bladder subheading, you will have many usual services. But you also want to pay attention to the urodynamic category. When you're coding for this subheading, it will help to know the anatomy of the bladder, which is why if you have a nice illustration in your CPT book, it probably would be a good place for you to make any notes that you want to be helpful for your exam. Your incision codes underneath the bladder. This is where you have a cystotomy for lesion destruction, insertion of radioactive material, and fulguration. Fulguration is the use of electrical current. Excision. This is for cystotomies and cystectomies. These codes are divided based on the extent of the procedure. Why are aspirations done? Darcy, why do you think aspirations are done in the bladder?
To remove the urine from the bladder.
Yes, to remove the urine from the bladder. And if they're going to use imaging, they will use a separate code to report that. Introduction codes underneath the bladder will be codes 51600 through 51720. 51600 through 51720. These are injection procedures. You'll notice these first 10 are injection procedures, and the radiographic supervision and interpretation will be reported separately. The installation of anti-carcinogenic agent via a catheter for bladder cancer. Pay attention to this code because their retention time is included. So the catheter in these procedures can be a simple Foley catheter if it's a simple procedure, but a complicated one might be for an anatomical anomaly or a catheter fracture. So you just want to, again, pay attention to the report and query the provider. Urodynamics. Over on page 694, urodynamics. 694 in your textbook, page 330 in your CPT book. Urodynamics are procedures that relate to motion and flow of the urine, so the motor and sensory function. These are used to determine urine flow obstructions. You will find a lot of these codes are bundled. All usual necessary instruments, equipments, and supplies and technical assistance will be bundled into the codes. You want to always code the urodynamic code in addition to all other cysto codes, if both are performed, and use a modifier 51 for your multiple procedures. Repair and laparoscopy. The repair codes are for cystoplasty, cystourethroplasty, a vesicourethropexy, and a urethropexy, which is urinary incontinence. Laparoscopy is for stress incontinence procedures. What is a cystoplasty, Fran? A cystoplasty is a repair of the bladder. So plasty, repair, or the bladder. A cystourethroplasty is repair of the bladder and the urethra. And the urethropexy is repair of the urinary incontinence. Now, an endoscopy on page 694, you will find that there are many combination codes here. The endoscopy codes start at 52000 on page 332 in your CPT book. And as I mentioned, many combination codes will be found in this section. There are notes before 52000 that indicates that it includes the myotomy, the urethral calibration, urethral dilation, urethroskopy, cystoscopy, and ureteral catheterization. So take special care when you're reading these notes to read the codes very carefully and pay attention to the descriptions. A lot of your third-party payers have edits on these codes that cannot be reported with other codes. Your endoscopy, cystoscopy, urethroskopy, cystourethroskopy also is assigned for IVP if it is appropriate. So that's your 52000 code. It is assigned for IVP if appropriate. 52005 is assigned for a retrograde pyelogram. And when you're coding for the cystourethroskopies with dilation, you want to ask yourself 3 questions. Is the patient male or female? Is it an initial or a subsequent procedure? And was general or spinal anesthesia used? Additional time and effort of the second procedure, and you may need a modifier 22. Transurethral surgery. Over on page 695, transurethral surgery, and page 333 in your CPT book. This works on the urethra and the bladder. What is a TURBT? TURBT. What can you tell me, Darcy? TURBT, bottom of page 695 in your textbook.
It's a transurethral resection of a bladder tumor.
Yes, very good. This is where they do an excision or a fulguration of the bladder tumor. The ureter and pelvis will include insertion and removal of temporary stents. And with these codes, they are divided by, is it urethra and bladder or ureter and pelvis? Over on page 696, the vesicle, neck, and prostate. These contain codes for the transurethral resection of the prostate. An example of this is 52601. 52601. Codes in this category are going to be based on approach. Pay attention to the approach. And on page 697, the urethra. 697 in your textbook, the urethra and page 336 in your CPT book. The urethra, the excision, repair, and manipulation. These codes are divided based on whether or not the patient is male or female. So again, just highlight or underline male or female. And then the dilation codes under the manipulation category are based on whether or not it is initial or subsequent, and if the patient is male or female. So you see that a lot throughout these code descriptors also. Simple, complicated, initial, subsequent, male, female, repair, incision, excision. Age is another part. Percentage is another part. All right. Any questions on that section? All right, let's move on to page 699. You'll notice that the male system, the anatomic subsection, again, the subheadings of the male systems are divided into the anatomical subheadings. The basis for the division of the categories are divided by procedure, so anatomic and procedure. And you will find that the largest category are the codes 54000 through 54015. Again, your format are procedures, incision, destruction, excision, introduction, repair, manipulation, and suture. Your biopsy codes on page 699 in your textbook, these are located in the subheading to which they refer. So your biopsy codes will be found in the excision subheading. Excision subheading. Your incision categories, they actually differ from the integumentary system codes. Your penis incision codes are for deeper structures, such as the erectile tissue. Underneath the incision category, pay attention to whether or not it is the integumentary system or the urinary system. Your destruction codes, these are divided on whether or not it is simple or extensive, or what's the method of destruction, chemical or cryosurgery. The extensive destruction can be by any method. Your excision codes on page 700 in your textbook. Your excision codes are commonly used for biopsies and circumcision. These would be appropriate when they're based on the method and the age of the patient. So again, method and age of patient. And then your biopsies are simple or complex. Okay, Peyronie's disease. This is a curvature, and it's a result of plaque formation. There is such thing as surgical removal of the plaque, and sometimes grafting may even be necessary to correct the defect. There are two areas for treatment of this disease. It's in the excision category and the introduction category. Your circumcision codes are based on if a device was or was not utilized. They also, if you're using a clamp, will use code 54150. If no clamp, it's usually for a neonate. And anything less than 28 days is a non-neonate. introduction codes, you will find that there are many procedures for the corpora cavernosum. The injection procedures for the Peyronie's disease is the toughening, and there are tests for erectile dysfunction. You will notice that there are two codes that have a global, professional, and technical component. Those codes are 54240 and 54250. Your professional modifier is what, Fran?
I'm sorry, I just came back. Ask me that one more time.
Your professional modifier is what?
Hold on. Oh, sorry, I was in the ladies' room.
That's okay. I just can't see
26.
that.
26.
Yes. And what is the technical component, Anita? The technical component would be a TC modifier.
There you go. Yep. You're right.
All right, so page 701 in your textbook. Repair. You will find many plastic repairs underneath the repair category under the codes 54300 through 54440. Some repairs are staged, more than one stage. So if there's more than one stage, modifier 58. The stage will be indicated in the code description. And the repair of the wounds involving the skin and the subcutaneous tissue of the external male genitals. If they're involving the tissue, see the integumentary section. The chordae and the hypospadias. The chordae is the ventral curve. The hypospadias is the congenital abnormality. The repair codes report the repair services for these two conditions. There are also certain degrees. On page 702 and 703, testis, we have excision and biopsy. When they talk about orchiectomy, these codes are either simple or radical, unilateral or bilateral, with or without testicular prosthesis insertion, and is what approach is used. You will notice that also underneath the codes 54550 and 54560, there is exploration. They also have repair, and your code selections are going to be based on approach. Is it inguinal, scrotal, or abdominal? You will notice also with these codes a lot of CCI edits. Over on page 703, epididymis. Epididymis. This is the narrow coiled tube on top of the testis. It connects that efferent ducts to the vas deferens. Incision and drainage abscess of a hematoma, use code 54700. On page 704, at the bottom of the page, codes 55100 through 55180. If you notice in your CPT book, on page 344, it is only 3, 4, 5, 6 codes, and it all relates to the scrotum. This is where you might have sites for lesion, abscess, or hematoma, where they would do incision and drainage. The vas deferens, over on page 705, this is the tube that conducts the sperm from the testis to ejaculatory duct and urethra. You have underneath this heading, incision, excision, introduction, and repair. So if you were to have a vasectomy, you would look for it underneath excision. Over on page 706. On page 706, figure 24-13, you would use a modifier 50 here for bilateral procedure for the code 55500. For the varicocele, this is trapped blood that causes vessels to swell. So for excision, you want to know what approach is being done. Is it the scrotal approach, abdominal laparoscopy? The excision of the varicocele and the hernia repair is using code 55540. When you're watching or looking at these codes, pay attention to separate procedure designation. Does it say separate procedure? On the bottom of page 706, seminal vesicles. This is a pair of bands that are posterior to the bladder. They provide the majority of the fluid. You also have incision, which is a vesiculotomy, and an excision, which is a vesiculectomy. On the incision, pay attention to, is it simple or complicated? On the excision, pay attention to what are they removing and what is the approach, and if it's bilateral, use modifier 50. On page 707, the prostate. A BPH is a benign prostatic hyperplasia. This is where you have enlargement of the prostate. The treatment options are a permanent or a temporary stent. They might use microwave heat or radio frequency, and when they do, they have different acronyms for that. A TUMT or a TUNA, tuna or tumped. What are some of the symptoms of a BPH? They might have urinary frequency or urgency. Over on page 708, they talk about laser coagulation, vaporization, with or without resection. Over on page 710, brachytherapy. This is a type of radiation treatment for prostate cancer. Usually utilizes high dosage of rate or low dosage. The high dose is a temporary method. The low dose is the permanent implants or the seeds. The placement can be transperineal or open exposure. And it's typically performed in conjunction with a urologist and a radiation oncologist. And in your CPT book, you have nice white space on page 347 and 348, which means that you have room for notes. All right, you will also notice on page 347 in your CPT book, they talk about reproductive system procedures and intersex surgery codes. All right, any questions in this chapter? We're going to take a quick 5 minutes and then we'll come back and finish the next chapter. Now I can see you guys. All right, on to page 715 in your textbook. Page 351 in your CPT book. All right, so what are the two categories that are contained in the subheading for ovary? Who can tell me that? What are the two categories of codes that are contained in the subheading for ovary?
Incision and excision.
Yes, incision and excision. And let's see. In what category are IUD removal codes found? In what category are IUD removal codes found?
Introduction.
Yes, introduction. Good job. All right, with the reproductive system procedures, these report placement of catheters and needles into the pelvic organs and genitalia for subsequent interstitial radioelement application. And then, as I pointed out to you, the intersex category codes, that's either male to female or female to male. These are considered complicated procedures that are completed over extended periods of time. You'll notice with the female genital system, as we've seen throughout, that it is the anatomic division. And you will see that there are many bundled services here. The sites are then further divided according to the type of procedure in addition to codes for in vitro fertilization that are later appended into the section. So, although the subsection includes a wide variety of codes for minor procedures, there are codes for these minor procedures that you will find are often bundled into major procedures. What will be important for you to determine when a bundled procedure is coded, whether they are bundled in or not. The female genital system starts with the vulva, perineum, and introitus, then moves into the vagina, the cervix uteri, the corpus uteri, the oviduct and ovary, and in vitro fertilization. The first 6 categories, they do represent anatomical regions within the female genital system. So, let's start off with the vulva, perineum, and introitus over on page 716 in your textbook and page 351 in your CPT book. The Skene's glands are coated with the urinary system under your incision or excision codes. This is a group of small mucus glands at the lower end of the urethra. The categories, again, that you will see here are incision, destruction, excision, repair, and endoscopy. Now, what you want to pay attention to here is that the Skene's glands are part of the urinary system, not the female genital system. Okay? The Skene's glands are part of the urinary system, not the female genital system. Underneath incision category on page 717. What do we find here? Incision and drainage. Incision and drainage of what? An abscess. On what? It could be the vulva, the perineal area, or the Bartholin's gland. Destruction. This is where the lesions are destroyed by a variety of methods. Destruction equals eradication, not excision. Excision is removal. Pay attention to this. Destruction is eradication. Excision is removal. 2 very important words to remember. Your destruction section is divided by simple or extensive destruction. The complexity is based on physician's judgment. Extensive would imply greater physician work, degree of difficulty, or number of lesions destroyed. It would be stated in the record. The global period for this would be 10 days. So your destruction codes have a global period of 10 days. If the patient returns in 2 days for a recheck, it will be included in payment for the original procedure. And if you have destruction, remember there's no pathology report. Why? Why, Fran?
There's no tissue to take. It's all been destroyed.
Perfect.
Woohoo! Which one has the 10-day global period? The excision?
The destruction.
Destruction. Okay. Thank you.
Destruction codes. 56501 and 56515. Those codes. 10-day period. 10-day period. Your excision codes. These are your biopsy codes. And they include local anesthetic, biopsy, and simple closure. And the codes are based on the number of lesions. And you make sure that you place the number of lesions in 24G on your CMS 1500 form. Codes 56605 and 56606. Take a look at those in your CPT book. 56605 and 56606. You will notice that these are designated separate procedures. If another service code from a female genital subsection is performed at the same session, separate procedure codes would not be billed separately, because it looks like, what? It's an add-on code, right? 56606 is an add-on code. But your add-on code does not stand alone. It has to be added to 56605. A vulvectomy is surgical removal of the portion of the vulva. This is based on the extent and the size of the area that is removed. When we talk about the extent of the excision, this is either simple or radical. When it's simple, it is the skin and superficial subcutaneous tissue. When it is radical, it is the skin and deep subcutaneous tissue. And then we want to know the size. Is it partial or is it complete? Is it less than 80% or is it greater than 80%? If it's partial, it's less than 80%. If it's complete, it's greater than 80%. So we want to know the extent and the size on the operating report. And pay attention, because some of your vulvectomy codes include a lymphadenectomy. If they code 56640, that is a unilateral procedure, and it does not have a code to describe bilateral. So if it was a bilateral, you would use a modifier 50. On page 718 in your textbook under repair, there are many plastic repairs here. Read your notes following your category. If the repair procedure is for a wound of the genitalia, use integumentary code system codes. If you're doing an endoscopy by a means of colposcopy, look for with or without biopsy. Over on page 719, these codes are divided based on the service. Is it an incision or an excision? So the codes underneath the vagina subheading are based on the service delivered. Two of your most often confused procedure codes here are within this heading, this subheading. It's the colpotomy and the colpocentesis. The colpotomy, you will find, is cutting into the vagina to gain access to the pelvic cavity. The colpocentesis is an incision of the vagina to gain access to the peritoneal cul-de-sac, which is that area that's between the uterus and the rectum. And this is where they would explore to drain an abscess. If the colpocentesis is part of a more major procedure, it will not be coded separately. Introduction at the bottom of page 719, introduction codes. These include the vaginal irrigation, the insertion of devices, a diaphragm, a cervical cap, or a pessary. Who can tell me what a pessary is? Over on page 720, what is a pessary? Darcy?
A support device.
Yes. It's what happens when women, of any age really, but usually women who have had hysterectomies or have had too many children, and it's basically what's happened is your pelvic floor muscles have don't have enough strength anymore to hold you all together. So a pessary is inserted to help support all of that for a woman. Lovely, huh? Look what we have to go forward to. So do those Kegels. Okay. When we're reporting HIT-PIT codes, so devices, equipment, what codes can we use? Fran? $99070 or the appropriate HIT-PIT code. Coverage for supplies will be based on the payer. Fran, what are you doing?
That's Anita's bag. She's getting into it. That's what that was. Sorry.
Okay. All right. For code 57180, take a look at 57180. 57180, you might want to make a note to yourself right there. That has a 10-day global period. 57180. 57180. On page 353 in your CPT book, 57180, 10-day global period. Your repair codes on page 720. These are for non-obstetric repairs. The obstetric repairs would use your maternity care and delivery codes. The global period here would be 90 days. Make sure that you review the operative report for the specific details. Over on page 721, your manipulation codes. This is where you would see dilation, the procedures that are done under general anesthesia or spinal anesthesia. Fran, what is dilation? What do they do for dilation?
Oops, sorry.
What's
Dilating
used
the
to do
vagina,
dilation?
well, I know they can do it with a speculum.
That's it.
Yeah.
Dilation is when the speculum is used to enlarge and using a dilator. Also under manipulation is where you will find foreign body removed from the vagina without anesthesia. This would not be an appropriate place to bill for pelvic exam under anesthesia unless other related procedures are performed at the same time, such as a D&C. Endoscopy, on page 721 in your textbook, the endoscopy codes are for colposcopies, and the colposcopy codes are going to be based on purpose. So, are we doing a biopsy or a diagnostic? Are we using a leap? What is a leap? Darcy, what is a leap? L-E-E-P. It's over on page 722. LEAP, L-E-E-P.
A loop electrode excision procedure.
Yes. It uses a heated wire to excise. It's also known as diathermy. It would also include a laparoscopic approach for repairing any perivaginal defects. What is a colposcopy? Anita, colposcopy. What is a colposcopy? A colposcopy is what enables a physician to view an endocervical polyp. And so a physician will use a colposcope, and that helps him to directly view into the vagina and the cervix. And a colposcopy may be performed, and a colposcopy usually is a polyp that is protruding through the mouth of the cervix. Cervix uteri, on page 722 in your textbook. The cervix uteri, this is narrow, it's the lower end of the uterus. This is where services will include an endoscopy, an excision, a manipulation, and a repair. Pay attention or note the location in diagram A in figure 25-1. 25-1 is all the way back on page 716, diagram A. Where is the cervix uteri located in that illustration? All right, so pay attention to those. Over on page 722, figure 25-7, you'll see there the electrosurgical loop, that's the LEAP. Over on page 723 in your textbook, you'll see the figure 25-8, that's conization. This is where removal of cone of tissue from the cervix. The LEAP technology can also be used for this. The corpus uteri. You're going to see a lot of complex procedures here. Corpus uteri. Over on page 355 in your CPT book. Corpus uteri. You want to pay attention here because you will often find similar wording in the code descriptions. So this section will require careful reading. Excision. This is dilation and curettage. hemorrhage service with the 58120. Instead, you would use 59160 out of the maternity and delivery codes. So why would a DNC be performed? Fran, can you tell me why would a DNC be performed?
I know that sometimes if someone is miscarried and there's still products of that miscarriage in there, those need to be
Yes.
removed. Sometimes they'll do that to get it
Yes.
all out.
Yep. Okay, and pay attention because some of your third-party payers will not pay this if it is performed with any other pelvic surgery because it would be considered to be part of that other surgery. It is not listed as a separate procedure in a CPT. Okay, turn the page. Excision. This is where you have your hysterectomy codes. All right, this is based on approach. Is it a vaginal or an abdominal? And what is the extent? Is it uterus or fallopian tubes? Your hysterectomy codes, they represent most of the codes in this heading. They also involve the removal of the uterus, but there are many variations. So, these hysterectomy codes are first divided on approach, and then whether or not they're abdominal or vaginal, and then by extent. So is it additional structures were removed or procedures performed? So it's going to be important for you to carefully review all of those hysterectomy codes when you're coding this procedure. You don't want to overbill and you don't want to underbill. You don't want to unbundle. And often you will see too that secondary procedures are performed with hysterectomies. So do not code the secondary related minor procedures separately. Some of them might be a biopsy or removal of a fallopian tube or an ovary. Okay? Those would not be coded separately. Introduction codes, page 724 in your textbook, introduction codes. The common procedures here are insertion of an IUD. Again, report the supply separately. You will also find that there are special or specialized services. Artificial insemination procedure would be one of them. Also, underneath introduction codes, you will have component coding. These are going to be necessary with catheter procedures for the hysterosonography. You are going to find notes following codes, including radiological guidance component codes.
Hey, Doreen, I have a question for you. If someone were getting an IUD inserted, would you go into HCPCS and look for that item in there to list the supplies separately then? Okay.
Yes, yes.
Okay.
All right, your laparoscopy and hysteroscopy on page 725 in your textbook, the bottom of 725. On page 357 in your CPT book, these are divided on approach. Is it for the removal of myomas or uterus? And the codes are going to be divided by tissue and weight. And also, this is usually done through the abdomen. The hysteroscopy is through the uterus. It's a surgical laparoscopy with vaginal hysterectomy. On page 726 in your textbook, oviduct and ovary. The oviduct is what, Darcy? What is the oviduct?
A fallopian tube.
Yes. And these are going to be incision categories that will contain tubal ligations. When they are done during the same hospitalization as the delivery, the ligation is coded separately. So watch for your separate procedure codes. Laparoscopy, over on page 727. These are based on purpose of the procedure. So such as lesion removal. If it is only a diagnostic laparoscopy, do not use the female genital system code. Use the digestive system codes. Underneath ovary, you're going to see two categories only. Incision and excision. On page 359 in your CPT book. The incision will be primarily for drainage of cysts and abscess divided on surgical approach. And the excision will be biopsy, wedge resection, and oophorectomy. And your in vitro fertilization on page 728. You will see that these are specialized codes that are used by physicians trained in the fertilization procedures. These codes will be divided by the type of procedure and method that is used. All right, any questions up to this point?
No.
All right, let's talk about maternity care and delivery. These are going to be divided by service. So is it an antepartum service, type of delivery, and abortion? The antepartum service would be amniocentesis or fetal non-stress test. The type of delivery would be vaginal delivery, C-section, or delivery after C-section. And then the abortion. Underneath the maternity and delivery notes, you're going to see a lot of notes that are must-reads. And these codes underneath the maternity care and delivery will describe a global service or portions only. So if you see delivery only, it covers delivery only. A lot of your notes are and detailed guidelines for coding services from this section will be provided for you. It's just important for you to know where to find your guidelines, so where to go for your guidelines, and make sure you're reading these notes. Fetal gestation. Fetal gestation is approximately 266 days, which is 40 weeks. When we talk about EDD, we're talking about the estimated date of delivery, which is 280 days from the last menstrual period, or LMP. Trimesters. On page 729 in your textbook, trimesters. The first one is LMP to week 12. The second, weeks 13 through 27. Third, week 28 through EDD. global package and delivery. If it is an uncomplicated maternity case, it would include the antepartum care, which is before birth, the delivery, and the postpartum care, which is after birth. The codes in this section describe the global obstetrical package and on the basis of delivery. So if you look at code 59400 in your textbook, in your CPT book, code 59400, page 362 in your CPT book, you will notice that it starts out with vaginal delivery. If the physician provides only a portion of the care, you would use the code that describes the care as the delivery only or postpartum only, according to the delivery method that is used. Your antepartum care, page 731, antepartum care, it would include initial and subsequent history and physical, blood pressure, weight, routine urinalysis, fetal heart tones, monthly visits to 28 weeks, twice a month visit weeks 29 to 36, and weekly visits from week 37 to delivery. You would code the services that are not related to antepartum care separately. So a pregnant female with complaint of a suspicious mole on her left shoulder, that is not part of antepartum care. When they're visiting the OBGYN who is providing the antepartum care, that is when you code the antepartum care. Service regarding the mole, not antepartum care. What would delivery include, Darcy?
I'm not sure.
Okay, so delivery would include admission to the hospital and the admitting ancient history and physical, management of an uncomplicated labor, vaginal or cesarean section delivery. If you have complications, they're going to be coded separately. Placement of an internal fetal and uterine monitor, delivery of the placenta, induction of labor, artificial rupture of the membranes, and injection of local anesthetic. You would report separately any fetal scalp blood sampling, external cephalic version, and administration of epidural. Postpartum care would include hospital and office visits following the delivery. This would be exploration of the uterus, episiotomy and repair of cervical, vaginal, or perineal lacerations, and placement of a hemostatic pack or agent. Then you would have normal follow-up care for 6 weeks after the delivery, which would include any hospital or office visits. Those are not going to be reported separately. So that's an awful lot of care included in the services, but when you go to bill these services, that's what is considered. And that's how it's all broken down and taken care of. Now, the antepartum and fetal invasive services, this is where amniocentesis comes in. This is when they insert a needle into the pregnant uterus and they withdraw fluid. And it's done with ultrasound guidance for this service. Why would they draw amniotic fluid, Fran?
To check for any abnormalities or any disease and defect, yeah. Genetic defects.
Stuff like that,
Yeah.
right? Yep. And so with this, you would want to pay attention to component coding because it's often part of the service within this subheading. Fetal services would include stress tests, blood sampling, monitoring, and therapeutic services. So your OB ultrasound codes would fall under your radiology codes. Postpartum curettage, this is removing the remaining pieces of the placenta or the clotted blood. And introduction, insertion of the cervical dilator. This is used to prepare the cervix for an abortive procedure or delivery. Cervical ripening agents may be introduced to prepare the cervix to soften and open it. Cervical ripening, they actually use the Bishop scoring method. You'll see that on the bottom of page 732 in your textbook. The repair codes over on page 733. These are only for repairs during pregnancy, not for repairs that are done during or after delivery. The routine global delivery codes, I pointed those out to you, 59400. And through that section, those are your routine codes. Episiotomies and use of forceps, these are included in delivery. They are not reported separately. The physician, when they provide only a portion of the global care, the global delivery codes do not get used. With the delivery of twins, the payers differ on the reporting format. Some want to see modifier 22 and some want to see modifier 51. 22 is unusual procedure services and 51 is multiple procedure. So the standard obstetrical package will include a single live birth. For multiple births, this is considered an and that is it for the female.
Can you just repeat that last part? For some reason you froze for like a couple minutes.
Fran, what did I say?
I don't know, you froze here too. You were just in midair and that was it. We're like, uh-oh.
Okay,
Not
what
again.
was the last thing you heard?
Twins.
About the twins, and then
Okay.
that was it.
Okay, so the delivery of twins, the payers differ on how they want to see that reported. They might want it with a modifier 22 or a modifier 51. The modifier 22 indicates unusual procedural services. Modifier 51 indicates multiple procedures. So you would just have to find out how do they want to see it reported when you send in a claim, when you code it. Abortion services, this can be spontaneous, incomplete, missed, or septic. The spontaneous means that it happens naturally. Incomplete requires medical intervention. Missed is when a fetus dies naturally during first or second trimester, and a septic is a missed abortion with an infection. For the abortion services, there is medical intervention. They perform a dilation and curettage or evacuation, which is suction removal. Then they use saline or urea to clean, and vaginal suppositories. A medical intervention may be even used to induce an abortion. It just depends on what is going on. Again, those codes will be based on the procedure that is used. Sometimes a hysterectomy even may be required. It just depends on the situation and what's happening. So, are there any questions for Chapter 25? Did everyone do the chapters? And homework? Did you do the report?
No. I'll
Okay.
just admit now, no.
That's fine. Daniel? Okay. All right, so give me 1 second. Let's turn to page 157 in your workbook. All right. So, the first report. Let's do number 58. Sorry, wrong page. Number 79 is report 36. Report 36 is an operative report. Pre-op and post-op are the same. Procedure performed is a cystourethropy insertion of bilateral ureteral catheters. So what are we going to code there? What's the procedure?
The cystourethropy.
Yes, cystourethropy.
Page 234.
Cystourethropy. Yes.
The report.
Okay. So go ahead. Look it up. All right, Darcy, what do you have?
52332 modifier 50.
What do you have, Fran?
I had 52005, modifier 50.
What do you have, Anita?
Yeah, same thing, 52005.
What do you have, Dan? I want you to look up this code and tell me why yours is not the right one. It's 52204. 52204. 52204.
Are we doing 36 or 37?
36. Oh yeah, I guess I should tell you. Okay, so
Because I didn't see any
I'm gonna go ahead and
biopsy
land
in
here,
there.
but I don't see that they just looked around, but they didn't touch anything.
okay, so hold on.
Just window shopping. Oops.
Sorry, my mind. All right, so
Alright.
the codes that you should have. Five two 332. Modifier 50. I apologize. If you had that, then you are correct. I did the wrong one.
That's okay. It's 52332.
Which one? What, 36?
36, yep.
How come?
Yep, 36. 52332 with a modifier 50. You could also have done that with an RT and an LT. So 52332 RT, 52332 LT. You could have done it this way or this way. Again, I'm very sorry. I did the wrong one. Where was my head at? All right, let's do number 84, which is report 83. Number 84, which is report 83. this one, the procedure performed, left groin exploration with orchiopexy. What are we going to look up on that one?
Doreen, when we're done with this one, we were just wondering if we can go back to 36 once we're done with this one.
Yep.
Okay, thanks.
Okay, so orchiopexy is the main term that we're going to look up here. What type of approach? What's the groin? Inguinal. Inguinal.
Which one we are doing right now? I lost.
Number 84.
Oh, 84.
It's report 83.
Okay.
Okay. What do you have, Fran?
I'm still looking.
What do you have, Anita?
I think 54692.
Darcy?
54640.
Daniel?
54640.
And just remember to add the modifier for left or right. So 54640 with the LT modifier. All right, Fran, you said you wanted to go back to 36?
Yes. Hold on a sec. She looked at the wrong code for that. That's why. But so is that what you were wondering?
Yeah.
Yeah.
Totally.
No, never mind. We we figured it out. She
Okay.
didn't realize she looked at the wrong code. So we're cool. All right.
Okay.
Thanks.
Yep. All right. How about number 81, report 38? So what are they doing in 38? They're inserting something. What are they inserting? Page 235 in your book.
A
235.
double cuff.
Yep. What is a double cuff? It's an artificial urinary sphincter, right? So insertion of a prosthesis. What type of a prosthesis? A urethral sphincter. Because anything that is not ours, part of our body, is a prosthesis. And you don't have to code the supply, Darcy. Just the insertion of the prosthesis. Daniel, what do you have?
53444.
Darcy, what do you have?
53444.
What do you have, Fran?
Sorry, 53444.
And what do you have, Anita?
Doreen, I didn't get why prosthesis. Why do we have to select that?
Prosthesis.
Yeah.
Oh, it's an artificial. It's like a
Oh.
like a fake leg, but it's a fake bladder
Mm-hmm. Oh.
sphincter. So yeah,
Oh,
it's a
okay.
prosthetic thing.
I can see 53444.
Okay, so I want you to look at 53445 because you're all just one number off. It's 53445. And I know what threw you off because it says bladder neck sphincter probably is what threw you off.
Oh,
Is that right?
it's got the reservoir though. That's why.
Yeah.
Ah. Extra storage. Missed that.
Yep. And it's just those little things. So when it comes down to two codes like that, you've got to just dig into the meat of the report and see, okay, what am I missing? What is additional in that report that I'm
We
not?
have to analyze that is a device. That's why.
Yeah.
Okay?
Yeah.
All right, how about 25? Chapter 25, page 167. Okay, how about number 70, report 20? Number 70, report 20. Okay, report 20. Procedure endocervical and endometrial biopsy. So what are they doing for a procedure?
Biopsy.
What type? Endometrium. What do you have, Darcy?
58100.
Danny? Fran?
Yep, that's what I have. 58100.
Anita?
I'm still looking.
Still looking.
Okay.
Yeah, that's the one. 58110. No, 58.
58100 is correct.
Yeah.
58100.
100.
All right. Let's go on to number 71, report 28. Number 71, report 28. Report 28 starts on page 227. What's going on here? What's the procedure? It is delivery vacuum assisted. So it tells you exactly what to do, what to look for. Vaginal delivery. So vaginal delivery only. Okay, Daniel, what do you have?
I find vaginal delivery, but I can't say anything about vacuums.
Okay. So it would be vaginal delivery only. What'd you get, Darcy?
59409.
Okay. Fran?
I got 59409.
Anita?
I
She's still looking.
Okay. And Dan, you got it.
here I got 59400. Those three numbers, right? No. What is it? How did you get?
Huh?
How did vaginal?
It's vaginal only. She's never had a cesarean, so just vaginal delivery, 5,400. And look down through there.
Yeah. Here.
Yeah. It's vaginal only. Yeah, go past the picture and you'll see there's a couple more. She's only had vaginal deliveries in her life. So.
And we need a
Yeah.
vacuum assisted.
Yeah, just.
It ends up just being vaginal delivery only. Okay? 59409.
Why are we not considering vacuum assisted? Why?
Say that again?
means Why we are not looking for vacuum assisted?
Because it was just a straight vaginal delivery. Because she didn't have.
It's an extra word. There's an extra word, right? We might get confused, right?
Right. But that's what they were doing. They were confusing you. It's the understanding that it's just a vaginal delivery.
Oh, okay.
Whether it is vacuum assisted or not, it is a vaginal delivery. Okay?
Yeah.
Let's move on to page 228, report 29. What is the procedure being performed here? Darcy?
Cesarean section.
Yes. And what else is happening with that C-section?
She's having a tubal as
Right.
well.
So you're going to look up the C-section first, cesarean delivery first, and then a tubal ligation, and it's being done with a cesarean delivery. So 2 CPT codes for this one.
you're not going there tomorrow for the weekend. I'll see you next week. Yeah, Tuesday. Okay, see you on Tuesday. Good night.
No, I didn't mean to write that.
Okay, Darcy, what do you have?
59514 and 58611.
Okay, Fran,
I had the same thing.
Anita,
Oh, I'm still looking.
She's still looking.
okay. Do you have the first one?
No.
That's 59620, or,
What'd you say? 59620?
right?
59620.
I'm thinking, I haven't seen this one. Serious in delivery. Yeah, I'm thinking 59620. Is it correct?
No. 59514 is the first one for the cesarean delivery only, and 58611 is the second one for tubal ligation with cesarean delivery.
I was thinking cesarean delivery only. Yeah, fine. I confused. Yeah,
Okay?
yeah, I am.
All right.
All right.
Should I
Let's go
write
on
it?
to report number 30. Page 229, report number 30. The pre- and post-operative diagnosis are the same. The procedure being performed is an amniocentesis for fetal lung maturity. Okay? So when you hear something like fetal lung maturity, what does that say to you? What type of procedure will this be? It's going to be diagnostic. So what are they doing for a procedure?
Amniocentesis.
Right. So amniocentesis. Okay, what do you have, Fran?
I got 59000.
What do you have, Darcy?
Same thing.
Anita?
9000.
Okay.
59. The
So
same. Yep.
59000 is the correct code. 59000. Good job. Okay. I want to move into chapter 26, page 171 in your workbook. So you can put your CPT books away, you can put your ICD 10 books away. We're going to help you get started on your homework. Not that you need it. Okay, so page 171. I want you to tell me the main terms that we're going to start looking up, starting with number 21. Incision and drainage of an infected thyroglossal duct cyst. So what are we going to start looking up here? What do you think, Daniel?
The incision at the drainage.
Right, incision and drainage. Incision and drainage of what? Fran?
A cyst.
And where is the cyst located?
The
Thyroglossal.
yes, the
Yes,
thyroglossal
the
duct.
thyroid gland.
Yeah.
Yeah.
It's actually the thyroid gland, okay? Number 22, okay? Darcy, what are they doing here in 22?
Removal.
Yep. Removal of what?
Cerebrospinal fluid.
How about shunt?
Oh.
They're removing the shunt, okay? And where's the shunt?
In the cerebrospinal.
Which is where?
The spine. Oh, yeah,
The
okay.
The brain. Okay, number 23, suture of the posterior tibial nerve. What are they doing here? Suture. Suture of what?
No.
The nerve. The nerve. Okay. Number 24, lumbar sympathetic block. Okay. So they're doing. This one's a little tricky because lumbar sympathetic block on the left. Well, they're doing a block, but block of the sympathetic nerve. And how are they doing that block? They're doing it by injection. And what type of injection would it be? It would be an anesthetic. So that one's a little trickier because those are the types of things you have to think about when they talk about lumbar sympathetic block. Okay, it's not like they're taking a block and putting it on the lumbar sympathetic nerve. They're taking a needle and they are inserting it, injecting it into the sympathetic nerve. So it's that whole roundabout way of trying to get to the answer. All right, micro dissection, micro repair, ulnar digital nerve, left middle finger. What are they doing here? They're doing a repair. A repair of what? The nerve. And how are they fixing it? Micro repair. So that could be a suture. And what are they using to do this micro repair? A microscope, an operating microscope. 26, placement of a dorsal column stimulator with implanted generator with stereotactic stimulation of spinal cord. What are they putting here? What's placement?
Introduction.
Yeah, introduction or insertion. And what are
Yeah.
what are they placing? Right, a generator or a pulse generator. Where are they putting it?
In the spine.
Right, spinal cord.
God.
All right, 27, epidural injection of a steroid. What are they doing here?
Injection.
Injection. Where are they injecting it?
Caudal.
Into the tailbone, lower back.
Spinal cord, right. So this is what type of an injection? An anesthetic. All right. Craniotomy for drainage of an intracranial abscess, infratentorial. So what are they doing? Craniotomy. Reoperation, skull-based surgery, repair of dura mater due to leak of CSF of middle cranial fossa, myocutaneous flap graft. What type of surgery? Skull base. Repair of what?
The dura mater.
The dura mater. And it is to repair what?
Leak.
A leak.
CSF leak, yes. All right. 30, insertion of a cerebrospinal fluid ventriculoperitoneal shunt for hydrocephalus. What are they putting in here? A shunt.
Fluid.
Shunt.
Shunt. Where are they
Yes.
putting it? In the
I-
brain. Okay. And 31, what are they doing there? A hemilaminectomy. A hemilaminectomy. Yes, a hemilaminectomy. And they're not doing just one, they're doing two. Because you have two CPT spots there. Okay?
L1, L2, and L2, L3.
Mm-hmm. All right.
See, you have to see. Two nerve groups, so different left.
Turn to page 176 in your
Yeah,
workbook.
that's two different spots.
Yeah, and L1 and L2.
Right, yeah. So you got two.
All right. Number 38. What's happening here?
Incision and drainage.
Incision and drainage. 39. What's going on there? Decompression. Decompression of what? The optic nerve, yes. All right. Number 40. What's going on there? What are they doing?
Removal.
Page 176 in the workbook. And 41 is a laryngoplasty. (42) is reconstruction of the auditory canal. 43 is what? Stapedectomy.
Stapedectomy.
Yes. With what? Foot plate drill out. And what is happening in 44?
Excision.
Yes, excision. Excision of the lacrimal sac.
Not done.
All right. Good work tonight, people. Good work. All right, so, Daniel, what's your takeaway from tonight?
A lot of preparation for this.
Actually, that will prepare you.
Or well, I mean for the event, for
Yes.
what it leads into, but
Yeah.
yeah.
Daniel was just indicating that there's a lot of prep for the national exam for the physician review book. What is your takeaway tonight, Darcy?
I really liked how it was easier for some reason for me to follow along, like the first chapter you went through. And a lot of times, like throughout the class, I have a hard time following where you are in the book. So I don't know what was different, but it worked better this class for some reason.
All right, good. Good to hear. Fran.
Geez, I don't know. I'm on the spot. No, it's going good. I like when we actually get to talk these things through in class. It just kind of helps you see what to look at, what to take notes on, what to, just good practice.
Okay,
So
good.
yeah.
Anita.
I'm getting back again.
Okay.
Yeah.
The biggest takeaway, honestly and truly, the biggest takeaway that I can give you guys, honestly, is this is not about memorizing. Do not think for 1 minute, okay, here we are in week 11, okay? Can you honestly say you've been able to memorize any of this?
No.
Not
No.
all of it, no.
Okay? Because it's not about memorizing. It's about knowing where to find the information. Okay? So if I say to you, can you tell me what's under warranty on your vehicle? Can you? But if I say to you, can you show me where the warranty information is for your vehicle? You should be able to find that and give it to me, right? Or find it and let me know what's under warranty. This is the same thing. It's about reading the exercises, knowing how to pull out that information, and going to the books and finding it. You weren't 100% on tonight, and that is okay, because knowing how to find and fix your mistakes, this is where it needs to take place. And you know what? You're going to make mistakes in the real world too. But you're going to have the resources and people available to assist you. So use them. Don't think that you're going to leave here knowing it all, because you won't memorize it. I don't memorize it. There's no way.
Yeah.
When I started working on this new system, the allergy and immunotherapy, I just went to my CPT book and I tabbed it totally different. Just that section of codes, because I knew I would be going to that section of codes. The same thing with my diagnoses. There's only about 20 to 36 diagnoses that are used for allergy and immunotherapy. So I tabbed those particular ones. That's what's going to happen when you leave here. Depending where you end up after you have done all of this, you will find that niche and you will use your books. And you know what? Your CPT book, you don't have to renew your CPT book every single year. It wouldn't hurt to have an updated one every couple of years, because they do delete codes and they do make revisions. But you can also, with today's technology, go right on to Google and ask, is CPT 97010 still a valid code? Same thing with diagnosis codes. New diagnosis codes for 2016. Or new diagnosis codes for allergies, 2016. I think I Googled something for venom. Okay, venom is bees, wasps, and yellow jackets, and snake, and something else. There was like over 50 venom diagnosis codes. So it's not about memorizing. When you sit down for that national exam and when you sit for the simulations, it's going to be about time management and your guidelines. Go back through your guidelines, make sure you know where they are. And if you didn't tab them and you need the pictures of the tabbing and you want a little extra help, just let me know. But know where your guidelines are. And if you have a question when you're doing an assignment, go back to your guidelines. Hey, am I supposed to code it this way? I think I remember HIV, you're not supposed to do, the 042. That's what I'm talking about. All right, you guys are awesome. You're doing good work. I'll see you next week. Get online, do your exams, and do your assignments for next week. We're going to be doing 26 and 27, endocrine and eye. And email me if you have any questions. All right? Have a great week, everyone. Thank you.
Thank you.